Uh, Good morning. So, as we know, we were discussing about omitting. Different case studies related to omitting we were discussing, and today we will have few more cases related to omitting. In the last class, we have seen this case related to uh, increased intracranial tension because of slowly developing hydrocephalus. Okay, so today we'll have another case. Yes, an 8-year-old child. This is an 8-year-old child who is presented with vomiting off and on for the last 2 months. 8-year-old. This is not infant. This is the childhood period, of course, school-going period. So 8-year-old child present with vomiting off and on. Sometimes he has got the vomiting. Sometimes he is normal. So this particular thing is going on since last 2 months. The mother is very much worried. So why suddenly he get the vomiting? Suddenly he becomes normal. So like that. And vomiting is the main complaint, and vomiting is present more oftenly in the morning hours. And thereafter there is no any issues related to vomiting. Now again, morning vomiting is always considered to be seriously, isn't it? It should be always seriously considered. But this is an 8-year-old child. Okay. So thereafter, after the morning hours, once the morning hour is over, then there is no vomiting. So throughout the day and including night, he is all right. Next day morning again he has got the problem. So this is the pattern. There is no any other symptoms. And then you ask the personal history. In the personal history, appetite is good, sound sleep is there. There is no other bowel irregularities. Nothing is there. Everything is fine. Now this is the case. The mother is much worried. So suddenly he is getting such attacks of vomiting, and what I should do now. So when you look into this case, yes, as there is no irritability. Now suppose morning vomiting is there, isn't it? So that has to be taken seriously, as we know. But if that morning time vomiting, if it is associated with some other associated symptoms like irritability is there, like headache is there, okay, so like loss of weight is there. So if there is any associated symptoms are there, then yes, definitely it has to be taken seriously. But in this case, there is no such attack associated symptoms. Only vomiting is there. Okay, so chance of increased intracranial tension is less likely here. So there is no much chance of increased intracranial tension. Now, therefore, what may be the case in this case? What may be the cause? The cause in an 8-year-old boy who is going to school daily and in the morning hours only he has got this problem. So then cause is most likely to be some of the schoolistic problem. Okay, he has got some schoolistic problem. Either he don't want to go to the school, or he don't want the school environment, or he has got some particular max period or science period. In that day he want to miss the school. So most probably this looks like a functional vomiting. This looks like a psychological cause and as well as functional vomiting. So this is a clear-cut case of functional vomiting. So what is important is, although it is functional, that is morning vomiting makes the things very confused. So how you have to differentiate it, that I already explained. Sometimes child is having no problem on Sundays and other holidays. Only on the school days child is having the problem. So that is another important thing that you can identify. Okay, so this is therefore called as a functional vomiting. Okay, this is case number 1, and such cases we will often get. So, and how to identify this thing? Yes, you can ask them to admit in the hospital for 1 or 2 days, then child may deny it. Okay, or in the holidays there is no problem, only on the school days there will be problem. So the child is absolutely fine, but mother is more worried, and that is another issue where we can another point by which we can identify. Child is enjoying and he is seeing all the scenes, the drama and all, but only mother is worried very much, but the child is not at all worried. He is not sick looking and is fine and fit. So these are some of the points that helps to identify the functional vomiting. Okay, and When you ask also, it's a very vague presentation will be there. So when you ask all the details of the vomiting, how the vomitus is, whether it is bile mix, or whether it is food mix, or whether it is associated with the diarrhea, abdominal pain, where actually pain is present. So child is not able to answer all those things, and although he answers, is very, very vaguely he answers. So such a type of presentation helps to identify the functional type of vomiting. So this is also commonly seen in the day-to-day practice. Yes, now we move on to the next important case, that is, yes, read this case very carefully. Now, a 5-month-old infant, whenever infant comes with vomiting, we have to be very careful. A 5-month-old infant presented with persistent vomiting for last 1 month. Child is 5-month-old now. Since last 1 month, child is having persistent vomiting. Okay, persistent vomiting. And there is no other symptoms. There is no other symptoms, including GER, gastroesophageal reflux is also not present. Okay, nothing is there. 5-month-old infant presented with the persistent vomiting. The duration is last 1 month, except that there is no other symptoms. Okay, now let us see whether the child is growing well or not. That all history we want to take in this case. There is not even a GER. So if nothing is given in this case, that suggests that everything is normal. Okay, so there is no growth fall, I think. Okay, growth chart is normal, child is feeding well. The thing is, vomiting is there since last 1 month. Now, in pediatrics, most of the time we say left-handed history or left side history. Okay, so what do you mean by left side history? That means, see, one is right-sided history and another left-sided history. Right-sided history is what we take the present complaint and main complaint and all those things. Okay, when you are not getting any clue out of these, then we will go for left-sided history. Actually, left-sided history means personal history, diet history, developmental history, immunization history. So these are all some of the histories which usually we will call it as left-sided history. That means by means of present history, past history, treatment history, etc., if you are not getting any clue about the particular disease, then usually we will just turn on to the left-sided history, which includes the personal history, diet history, developmental history, immunization history, etc. That means now when you're not getting any information from the right-sided history, now we will give more stress on the left-sided history, so that we are now trying to poke up whether some of the clues are available anyhow. Okay, we try to take some of the clues anyhow. So this is called as left-sided history. So in this case, actually what is happening is 5-month-old infant only presented with the vomiting. And if you ask the mother, there is no history available, and she don't know why it is happening, and child is absolutely normal, everything is fine. Now in this condition, now just leave the right-sided history and go to the left-sided history. Okay, so left-sided history, if you ask the personal history in this particular child, then mother start telling some of things. Okay, child is irritable, child is also having anorexia, child is not eating well. Okay, there is also some constipation. So you have to ask this whenever a mother comes with such one symptom, vague symptom, which cannot be identified, which cannot be located or attributed to any particular system. Then as a physician, you have to try this method. Okay, so try to ask some of the personal history, diet history, etc., so that you can get some of the clues. So here when you ask this question, so mother is telling, child is little irritable. Sometimes actually this type of questioning may lead to leading question. Okay, leading question should not be asked, but you have to poke the history. Okay, ठीक है, आपका बच्चे को क्या है कि थोड़ा ज़्यादा जिद्दी होता है ना, इरिटेबल है ना, इरिटेबल है कि ना, सो इस टाइप का क्वेश्चन नहीं पूछना है, वो तो लीडिंग क्वेश्चन हो गया, ठीक है. बट थोड़ा बहुत ऐसे पूछना है कि पर्सनल हिस्ट्री में क्या मिलेगा आपको, क्या बच्चा कैसे रहता है, ठीक ठाक रहता है क्या कोई इरिटेबल रहता है या आराम से रहता है. सो लाइक दैट यू कैन स्टार्ट आस्किंग द क्वेश्चंस, ठीक है. सो इन दिस केस व्हाट हैपेंड इज a child is irritable and child is also having anorexia according to mother, and also child is not eating well, and there is also some constipation. Okay, now in spite of that, baby is passing excess urine. Okay, now mother is telling that all this child is irritable, anorexia, not eating properly and constipation, but actually mother is telling that baby is passing normally urine, excess urine. So now we can make the diagnosis of a condition called as idiopathic hypercalcemia. I will discuss it, what actually it is. On the other side, if you take the feeding history, which says that child is exclusively breastfeeding, child is happy and gaining the weight, but there is omitting with the normal developmental milestone. So we say that it is a normal child and we need to observe him very closely. So on the other case, sometime if it is present, you can ask for the family history to find out some of the rare conditions. Now these are all the possibilities actually we will have in this case. Okay, so now what actually mother is telling, that we will see. So now here, when you get into the personal history properly, so then you find out that there is anorexia, not eating well, nothing, irritable, etc. And the meantime, child is passing excess amount of the urine. So this much of history you got. Now, so this is actually seen in conditions of hypocalcemia. That hypocalcemia, why it is happening? That is because of idiopathic hypocalcemia. This is also commonly seen. So whenever patient comes with this particular type of histories, child is absolutely normal, feeding well, everything is fine, okay, but still child is some irritable, or mother is telling that he is not taking the food. So usually this is seen in case of idiopathic hypocalcemia. Okay, most of the time it is undiagnosed. Of course, this is one of the case where we can get such type of vomiting at a 5-month-old baby. 5-month-old, we know that that's a very important period. Starting from early infancy is very important period as far as vitamin D is concerned. We know that. Okay, that's the growth plates of the bones are growing, and the actually rickets is called as a disease of the early infancy. So now this is early infancy, 5-month-old period. So problem related to this hypocalcemia, okay, calcium absorption may be there because of some vitamin D deficiencies. And the vitamin D deficiency because of improper exposure to the sunlight, or maybe because of the diabetic problems. So there is no vitamin D, therefore the calcium is not absorbed, and that leads to such rickety like conditions. Along with the biochemically there is a hypocalcemia in the blood. So this type of presentation is possible. So this is one such case. Of course, you can get such cases in the routine practice. Now we go to the next case. A 16-year-old girl is brought with a history of recurrent early morning vomiting. Okay, a 16-year-old girl is brought with a history of recurrent early morning vomiting. 16, she is an adolescent girl. Okay, so she has no history of raised intracranial pressure. Early morning vomiting means everybody will be worried about intracranial vomiting, so pressure. So she has got no any history of intracranial pressures, and there is no family history of the migraine also. Migraine and as well as ICT. These are the two important causes of early morning vomiting which may occur. And she does not meet the criteria of cyclical vomiting also. It is not even cyclical vomiting. Cyclical vomiting comes in episodes, isn't it? 15 days, 20 days, episodes is coming. Now, what actually you want to ask over here? 16-year-old girl brought with a history of recurrent early morning vomiting. Everything is fine. Yes, anybody? What may be your idea? What may be your thoughts in this case? सब कुछ नॉर्मल है, इंट्राक्रैनियल प्रेशर बढ़ा हुआ नहीं है, माइग्रेन का हिस्ट्री नहीं है, साइक्लिकल वोमिटिंग नहीं है. साइक्लिकल वोमिटिंग कुछ मेटाबॉलिक प्रॉब्लम की वजह से या कीटोन बॉडी बनने से ऐसे सब होता है. वो बार बार आता है, एपिसोडिक मेथड में आता है वो, जैसे हमारा गठी यंत्र या ग्रहणी जो आता है उस टाइप से आता है. बट इस केस में क्या हो सकता है? 16-year-old girl brought with a history of recurrent early morning vomiting. Any idea?
प्रेगनेंसी हो सकती है ना?
Yes. What is your answer?
प्रेगनेंसी की वजह से.
Yes. Okay. Very good thought. Maybe because of pregnancy. As I told earlier, whenever an adolescent girl come, always you have to keep an eye on that part also. Okay. So let us see whether you are right or wrong. Yes. Actually, you are right. So this is actually a case of pregnancy. Okay. As the main clue is adolescent girl. Okay. So otherwise there is no any cause for vomiting in an adolescent girl usually. Okay, because she is well mature enough and she know which type of food she has to take, and she can express her feelings very normally if at all she is having migraine or some other structural problems, definitely it would have been identified earlier. Now, sudden onset of this type of vomiting in the adolescence period, okay, so that has to be always evaluated further. Okay, sometime bulimia nervosa. Bulimia nervosa is a almost a psychological condition that may lead to vomiting. What is that? That is binge eating. That means the adolescent girl will have an abnormal feeling that if she is consuming more food, she will become fat and body figure cannot be maintained. So therefore, after ingestion of the food, she forcefully omit out the things. So that's a different condition. That's a bulimia nervosa. That's called as bulimia nervosa. Okay. So that's a different issue, but such type of history is not there. But suddenly child started vomiting, okay, or child not, adolescent girl started vomiting. So always you have to suspect, because when you are sitting in the clinical OPD, clinical scenarios, this is also among the clinical scenarios. This is also one of the possibility. So we cannot get often, but as a pediatrician, we have to think about this possibility also. Anyway, so. Now let us see some of the important things. One is abdominal migraine. What do you mean by abdominal migraine? Okay, so
It's like okay.
So abdominal migraine. There is a condition called as abdominal migraine. Migraine means you know that there will be pain. Pain is the most important symptom, and it is triggered by so many triggering factors. That's the typical nature of the migraine. Okay, one-sided headache, which is triggered by some of the triggering factors, and there will be some sudden vascular changes which is taking place in the intracranial vessels, and that leads to some sudden constriction of the vessels or production of some unwanted substances, biochemical substances, etc., and that leads to the formation of a headache, and that is usually unilateral most of the time. It may be bilateral sometimes. So that's called as migraine. Intracranial migraine, we know that, okay, as far as headache is concerned, that is increased by the sound stimulus or some other stimulus, etc., or cold stimulus, thermal stimulus, sound stimulus, etc., going to increase the condition. That part we know. But this is a new term for us, abdominal migraine. What is actually abdominal migraine? Abdominal migraine is one of the common cause of vomiting in children. Okay. So there may be association of the headache also. Sometime it may be associated with the headache. Often we get the history of migraine in the child or in the family. Okay, so this is quite rare in the adults. The common trigger factors of migraine also trigger the abdominal migraine. Okay, so I will explain in detail. Usually it is associated with the abdominal pain, nausea, vomiting, headache, and light sensitivity. Light sensitivity. Okay, what is this? See, in the migraine, actually, what is the pathology taking place? As I told earlier, when it is happening in the cranial area, because of some of the triggering factors, there is sudden contraction in the vasculature, blood supply, etc. Okay, or some of the unwanted metabolites or some of these interneurons, interferons, or some cytogens, etc., they are produced. Okay, so they are produced, and because of which there is either sudden contraction of the smooth muscles of the artery, etc., lead into some hypoxia or sudden contraction, less blood supply, ischemia, etc., and as a result, this particular the pain will develop. Okay, so because of sometimes there is excess excess circulation of the blood in the vessel. Okay, so that leads to the pressure effect against the durometer. Durometer is very sensitive, and that leads to the pain. Okay, whenever there is excess pulsation is there in the artery because of over functioning of the smooth muscles, so that pulsation is more, so that is touching the durometer. Okay, durometer is actually very sensitive. ड्यूरोमीटर को जब भी टच करता है तो बहुत दर्द होता है एक्चुअली. सो ये जो बल्जिंग वेसल है वो ड्यूरोमीटर को टच कर रहा है, तो उस टाइम में जो है पेन होगा आपको, वो थ्रोबिंग टाइप ऑफ पेन आ जाता है ना, हर पल्सेशन के साथ जो है आपको एक दर्द आता है. वो क्यों आता है? क्योंकि पल्सेटिंग वेसल टचेस द ड्यूरोमीटर एंड एट दैट टाइम यू फील द पेन. Okay, so such a type of sudden hemodynamic changes can take place in particular area of the brain, cranium, leading to migraine. This is what exactly happening in the migraine. Okay, now what we are telling is abdominal migraine. Same type of pathology can also sometimes takes place in the abdomen. What happens? Abdominal vessels, Okay, there is a sudden sudden ischemia or sudden vascular changes in the vessels which supplies to the abdominal area, like small intestine, stomach, and this pancreatic area. Okay, so that is descending aorta branches. Sudden contraction of the vessels can occur, especially the vessel supplies to the intestine, like superior mesenteric artery, colic trunk, celiac trunk, colic, or the superior mesenteric artery, inferior mesenteric artery. So there may be some time sudden contraction of these vessels, and as a result, so there will be ischemia in the intestinal area, and that ischemia may lead to abdominal pain, nausea, and vomiting, or even sometimes headache and some of the light sensitivity, etc. So actually this condition is called as abdominal migraine. Sometimes abdominal migraine may be also one of the cause of vomiting. So when somebody is taking कि कुछ खाने के बाद शुरू हो जाता है, या कुछ पर्टिकुलर सिचुएशन में शुरू हो जाता है, कुछ ट्रिगरिंग फैक्टर की वजह से सडनली जो है वोमिटिंग, नॉसिया सब शुरू हो गया. सो दिस मे बी ए केस ऑफ एब्डोमिनल माइग्रेन. जस्ट लाइक इंट्राक्रैनियल माइग्रेन जिस तरीके से होता है, उसी तरीके से एब्डोमिनल माइग्रेन भी होने का चांसेस है. एब्डोमिनल माइग्रेन भी हो सकता है. ओके, सो दिस इज ऑल्सो पॉसिबल, बट ऑफकोर्स ये बड़ों में थोड़ा कम है, बच्चों में हो सकता है. बच्चों में थोड़ा ज़्यादा कॉमन है, बड़ों में थोड़ा कम कॉमन है. ओके, सो एब्डोमिनल इट्स ऑल्सो प्लस आई थिंक एब्डोमिनल एंजाइना भी बोलते हैं शायद इसको. ओके, जैसा हम बोलते हैं कि एंजाइना पेक्टोरिस, वैसे एब्डोमिनल एंजाइना, जैसा हमारा माइग्रेन है उसको वैस्कुलर एंजाइना भी बोलते हैं. सो है ना, माइग्रेन इज यूजुअली इंट्राक्रैनियल माइग्रेन ऑफ इंट्राक्रैनियल कॉज. इट इज ऑल्सो कॉल्ड एज वैस्कुलर एंजाइना बिकॉज द कॉज इज फ्रॉम द वैस्कुलर. ठीक है, वैस्कुलेचर में जो सर्कुलेशन में जो चेंजेस आते हैं उसी की वजह से आता है. ठीक है, सो यूजुअली माइग्रेन स्टार्ट, वी नो दैट, बाय मीन्स ऑफ एक्सपोजर टू सनलाइट और लाउड नॉइज. ठीक है, और जो बहुत ज़्यादा ठंड एक्सपोजर होने से, तो ये सब इसका ट्रिगरिंग फैक्टर्स है. ये स्टिमुलस का जैसा एक्ट करता है, और वो जो है वो वैस्कुलेचर को स्टिमुलेट करता है, और वैस्कुलेचर जो है हाइपर एक्टिव हो जाता है. एनीवे, सो दिस इज ऑल्सो कॉल्ड एज this is one condition where we can get the vomiting, that is abdominal migraine. So now another important condition is cyclical vomiting. Okay, this is also commonly seen in children. So what do you mean by cyclical vomiting? So throughout the discussion of this vomiting, many times we came across with this word, isn't it? Cyclical vomiting. So cyclical vomiting is a syndrome which is a chronic syndrome, chronic functional condition of unknown pathogenesis. Till date, exact pathogenesis of cyclic vomiting is not known to anybody. Okay, so usually it is a chronic functional condition. If you see structurally, you cannot get any findings, but still the problem is there. Therefore, it may be a functional problem. So therefore, it is a chronic functional condition. Now, recurring episodes of this vomiting lasting for single day to multiple weeks. So what actually happens is, patient is absolutely normal. Then patient is suddenly start with the vomiting, and this vomiting may end up in one day itself, or sometimes this vomiting may extend up to weeks together. Okay, एक बार शुरू हो गया तो एक ही दिन में खत्म भी हो सकता है ये, या कभी कभी weeks together भी जा सकता है. Okay, so each episode is usually divided into 4 phases: inter-episodic, prodromal, vomiting, and recovery phase. So इसको हम 4 फेज में हम यूजुअली वी विल डिवाइड इट. ओके, इंटर एपिसोडिक, प्रोड्रोमल, वोमिटिंग एंड रिकवरी. पहला जो फेज है दैट इज इंटर एपिसोडिक, देन कम्स प्रोड्रोमल फेज, देन कम्स रियल वोमिटिंग फेज, देन कम्स द रिकवरी फेज. सो दिस इज ऑल्सो ए माइग्रेन ग्रुप ऑफ सिंड्रोम विच ऑकर्स इन चिल्ड्रन. सो ये भी माइग्रेन जैसा ही है. इसका भी कॉज exactly we don't know, but some of the studies shows that some ketone bodies production होता है body में, and because of which this vomiting starts. Slowly there is a raising amount of the ketone bodies in the blood, and when it reaches the peak, then there is starting of the vomiting, and after vomiting these ketone bodies come down gradually, and then the recovery takes place. So this is one theory says, but exactly the correct diagnosis is not at known. So this is actually all about vomiting, what we are discussing. Okay, so we have seen so many case studies, and the case studies that we have discussed, 10 to 12 13 cases, they are the most common cases that you get in the OPD. And if you once you remember these cases, and definitely there will not be any much problem in dealing with the vomiting. One thing is very clear: when the newborn vomiting, whenever there is a mother comes with vomiting, you have to differentiate between the vomiting and regurgitation. Okay, and most common cause of regurgitation in the in newborn period is a arophagia. Okay, and faulty feeding habits. Okay, faulty feeding habits, arophagia, faulty method of feeding. Okay, and then deranged mother-child relationship or bonding. Okay, so that is also one of the most common cause, and that the primary factors you have to correct in most of the mother, especially in the primaries. This problem is more so because they don't know how to feed the baby and all. Sometimes mother is overcautious, that's also leads to this problem. Okay, so vomiting has to be taken seriously, that also I have given the timeline. Okay, in the newborn, if it is extending for more than 12 hours or after 24 hours, like that I have given in the first few classes, I have given the details. So you have to also identify what are the red flags of the vomiting. Okay, simply a one time vomiting or two time vomiting, you should not go for a unwanted investigations. Okay, most of the time the vomiting is self limiting. So this is all about vomiting as a clinical symptom and our approach. Thank you very much.